The reason this talk is first is because I'm speaking on behalf of the entire scientific committee of this Congress on something that will affect future Congresses, and so we thought we'd get it out of the way up front. And so you've already been introduced to the committee that worked towards selecting the presentations that you will see over the next 3 days. And as a group, we decided that it was time to propose a consensus view, a foundation statement, a constitution, if you will, for the purpose of future meetings. Now, this group has pretty significant experience and commitment to the advancement of hospital in the home, and we've been discussing these issues, some of us, for literally decades. And as well as that, whatever experience we had before we were associated with the Congress, now we have a unique opportunity and a unique access to see the work that's been going on by you all over the world because it's submitted to us to read and to learn from and to assess for the suitability for the Congress. So we have a lot in common, but we also have some differences. We all come from different countries, we all come from different health systems, we all work in different hospital and home services. So the process of coming up with an agreed set of principles and definitions was a challenge, and it did require debate, and it did require negotiation, and occasionally even some mild conflict. So I want to thank this group, who I consider my friends as well, for putting up with that exercise. So why, as well as organising this Congress, did we put ourselves through that painful process of coming up with a consensus? And there are a few reasons. I've labelled this the last Congress. I actually mean the first Congress, which was the last face-to-face Congress. And as you know, a survey was, or you might not know, but a survey was circulated among the delegates of the first face-to-face Congress by David Levine and Bruce Leff, and just to gauge some views about what people wanted from hospital in the home, what they wanted to learn from hospital in the home in the Congress. And a paper was produced, and there's another survey, if I'm not mistaken, going around for this Congress, and I'd encourage you all to be a part of it. So that survey result was disseminated, and in fact a paper was published in JAGS last year, and we didn't want to leave it just at that. We didn't want to leave it as just a publication that said what it was that you wanted. We thought, why don't we actually give the delegates what they wanted? And if you look down that list, one of the most frequently cited problems that people wanted solved was a definition for a hospital home model of care. Now, that's 20% of people who came to an International Hospital and Home Congress, paid to come to an International Hospital and Home Congress, wanted to know what hospital and home was kind of about. And we thought that was unusual, and we wanted to do something about that, rather than just leave it. This Congress, we worked really, really hard to give everybody who submitted a presentation the opportunity to have that work presented by you, either in poster or verbal form, or experienced or listened to by people who come. We worked hard. We weren't so tough on methodology. It's been a long time since we've seen any of you. We wanted people to share have the experience of sharing knowledge. And so we tried to be as inclusive as we possibly can. So there were over 300 abstracts submitted to this Congress, which is wonderful. But about 23% of those abstracts were rejected. And the abstracts went through a dual peer review process. So 25% were rejected. Now, the good and bad news before I go on is that figure I want to rise over the next Congress and the one after that. So there will be a higher rejection rate than that one. But nevertheless, it was still relatively high. And when we looked at the reasons why we rejected papers, the most common reason, in fact almost the universal reason for people's papers to be rejected was the comment that it was not hospital in the home. Now, we wondered, why is that? Is it that we haven't explained what we're doing here? Is it that people haven't explained their service well enough, which was a hospital in the home service, but we didn't understand that it was? Or was it that it wasn't hospital in the home? And so that was a reason to go on and try to make some kind of consensus statement about hospital and home. So why did we define it? As I said, this definition, what I'm about to tell you, is primarily for the purposes of this Congress, for this group, so that people know what they're submitting papers to, and people know when they come what they're going to hear. But there are other reasons to do it. We speak across national boundaries. We want to sometimes have external points of reference to do that. We don't want to keep explaining individual differences about national hospital and home services, even though there are. It would be great to be able to have a point of reference that was outside national systems. Engagement with patients, with payers, hospital physician community and health systems, we hope that this would help in people's attempts to do that. For people who are educating people, it might be useful to have an international consensus or definition about what it is that we do. You know, you'll want to publish your papers. The work that's been presented here, you won't just want to publish it in your own country's journals. You won't want to just publish it in your local hospital and home journal. You want to publish internationally. And if you want to, and we want you to publish internationally, this is how we want to proceed. This is how we want to advance. But to do that, it's important to understand that there are differences, and we want to try and minimise those differences, and having an international consensus might help you and help the journals understand what it is that we're doing. And similarly, when we come to review those papers, rather than a peer reviewer to rely on their own individual national experience or definition, they can use an international definition, and that might help. We've just spent half a day talking about technology. And we don't want to take technologies, products off the shelf designed for something else. We want technology, we want companies to understand exactly what it is we do and then go forth and help us do what we do and do more than what we do. But they will only do that if they have a deep understanding of what it is that we're trying to achieve. And my experience over the last decade is that it's very, very difficult to get companies to understand truly what it is that we do and what our needs are, and we hope that this helps. And finally, it's self-evident. We're growing very fast. This group is twice the size of the last time we were together. And I know that in my country and in other countries, we are growing very rapidly. What that means is that people who have no clue previously necessarily about what hospital and home is are taking positions in hospital and home. Health systems who are picking up the phone and deciding to move into hospital and home are doing so sometimes in a complete vacuum. And we want to help those people along the path of accepting what we do. Okay, but there's a big caveat, a big but. We're not intending to cut across any national country or any national definition or any individual country's definition, working or otherwise, of what hospital and home is and what hospital and home does. That's not our goal. We don't want to make life difficult. We don't want to have conflict. What we want to do is essentially use national definitions to inform this definition, and perhaps the other way around, where a country doesn't have a hospital and home definition as yet, be able to at least reference this. So it'll be an interplay, but please bear in mind what you hear today, if it's not what you practice in terms of a definition in your country, don't take it as an assault. So here's what I'll briefly be going through. We'll talk briefly about a preamble. I'm going to talk about the name of what we do, a definition, a model definition, some exclusions, a word on consent, and some research outcomes that we want to see presented. Most constitutions have a preamble. It's a statement of principle. It's a statement of purpose. It outlines to people, hopefully, what it is that you're here for and what it is that you want to do. And we thought it was reasonable to do that, and we wanted to keep it brief. And so here's what I think we're here for. We're here essentially to improve the lives of sick people who need hospitals. That's what we're here for. Their lives can do with some improving. And our job is to make their lives better. And how are we going to do that? We're going to do that by changing the culture of hospitals to deliver hospital-level care at home. Now, it's brief, it's profound, I think, but it's something that we can keep at the front of our mind and help guide us in everything that we do, definitions or clinical care or otherwise. Okay, so we come to names. Names are personal, names are special, names are very important. It's meant to be the most important word in the language that you come from, your own name. And so, you can't minimise the impact of a name. But in hospital and home, We have a lot of names, a huge variety. And sure, sometimes they reference people who are driving the concept in that country, and that's fine. Sometimes it's around funders who think that they've discovered this all for themselves, and so they come up with a new name. Sometimes it's just stamping marketing on top of what it is that you do. Someone thinks it would be much better name than the name that we're proposing. But it's confusing. It's confusing to people across different countries. It's confusing within the country when you're using a different name. It confuses patients. It's distracting. And I think that although there's validity in every name, there's also validity in coming up with a term that we can use for what we do across countries. And so we're proposing that the name or the names are hospital at home or hospital in the home, and of course that's in English, in those terms in your particular language are the terms that we would like to see. And we would want to see you use them in titles of reports, in titles of papers, and within the body and abstract of those papers. Why? Because that's where people will search. Okay, they'll go looking for hospital in the home, and you need to put it right up front and say, this is about hospital in the home. Where else do they search? Well, where did patients, doctors, medical students, you, me, we get our information from the internet, and we go to Google, even before we go to PubMed. And so I looked at Google Trends over the last 5 years, and the two terms that we've proposed there, hospital at the home is much more commonly used, about twice as often as hospital in the home. And those two are so far more frequent than the next highest, which doesn't register at all. So all those other cascading names that we saw don't rate a blip. And the point, of course, is that if the two terms were actually one, that the impact of that would be greater. And you can also see too that the terms have been searched more frequently over the last couple of years, which is a signal that people are more interested in what we do. So if they're more interested and they go searching, we want them to find us. Just like any company wants to be found when they are being searched in Google, or any minor celebrity, or any major celebrity. And it's also important when you're trying to distinguish us from others. So if you put in a term like OPAT and hospital and home, and you can see how, again, the growth in search terms for hospital and home over the last few years has outstripped that of something like OPAT. And if we had one term rather than two, the difference would be greater still. Okay. Why? We think it's reasonable to define hospital in the home, just as it's reasonable to define hospital. And you might think why do you need to define a hospital? Because you do. And people have done it, and they've had attempts. The World Health Organization has 60 years ago tried to identify it, and they tried to do it essentially for statistical purposes in order to compare apples to apples and oranges to oranges when you're trying to publish data on what you do. And they described a hospital as a building, essentially, that has sick people, injured people, or women giving childbirth, and then there's people, and it's there for observation, investigation, treatment, or rehab, and it has medical supervision. Pretty straightforward to us. The CDC, much the same thing, but a little bit more evolved. They're licensed institutions. They provide, again, diagnosis and treatment for medical conditions. They have an organised physician staff, and they have a continuous nursing staff, and they can provide inpatient accommodation. Now, there's no surprise there, except to say that within that definition, over the last, 100 years, but let's say just even the last 40 years, what goes into a hospital is vastly different from what it was 40 years ago. So the definition is constant. We all know what that definition says. We all know what we can all understand and recognise our institutions there, but what happens within that institution can change dramatically, and so it will be with us over the next little while. And the last point is that it's probably not a fixed beast. Our intensive care colleagues are still talking about what constitutes intensive care. This committee and the successors of this committee may still have to grapple with issues of definition, but hopefully we can come up with one that will stand the test of time. So here's what we think. We think that hospital in the home is an acute clinical service that takes staff, equipment, technologies, medication and skills usually provided in the hospitals, delivers that to selected people in their homes or in their nursing homes. It substitutes for acute inpatient hospital care. So we are forever linked to what happens in a hospital. We may criticise them, we may do all sorts of things about considering how it is that care operates in a hospital, but we are linked to what they do and will be. Let's explore that a little more by coming up with some consensus about what should be in a model. So again, it should comply with any regulatory or governance obligations. It's care that's hospital directed or by specialist physicians. It's episodic, it starts, it finishes. It's 24 hours, 7 days a week. And it's fully responsible for the patient during that episode of care. So all medical care, nursing care, allied health care, pharmacy, pathology, radiology, all of it. 24/7, hospital in the home, you have whole patient responsibility. Okay, now, it's easier to say what's not hospital care because the hospital can just say, well, anything that's outside is not in the hospital. Well, they used to be able to say that. So it's easy, but we operate in an environment where there's care going on in the community in all sorts of different ways. So we have to be a little more specific about what's not hospital in the home. Outpatient care is not hospital in the home, therefore OPAT, therefore self-administered IV care is not hospital in the home. Hospital in the home is not a prevention program. It's not a community-based chronic disease management program. It's not solely virtual care or solely remote telemonitoring. It's not day facility-based treatment. It's not primary medical care at home. And it's not community nursing or standard skilled home care. Nothing wrong with those things. Nothing wrong with them. Just not us. And I think that might mean that at least we make it clear to people submitting papers to the conference that's the reason why your paper might not have been accepted. Now, while they're all valuable interventions in the community, I'm working in hospital and home because I think what we do outstrips any of those other things. But that's me. A word about consent. This is actually not just about consent. So we believe, and we would assume, but we believe that the patients should actively consent to their hospital and home care. But more importantly, that if they withdraw that consent, they have the right to a hospital bed. So they have not foregone their right to a hospital bed because they come into hospital and home. Very important. And we've been talking about trust already this morning. It's about that trust. Okay. Finally, we come to some research outcomes. So we read a lot of papers, and we've learnt over time that there's some confusion in terms of some outcomes, and we want them to be tightened. Okay, so what we really want to see in your hospital and home services new latest expansion into the treatment of X is the unplanned return to hospital during the hospital and home episode. So we want you to tell us how many patients came back to hospital during the hospital and home episode. Okay? Now, it's not like overall survival in oncology. It's not like an echo. It's not like an echo measurement for a cardiologist. But we think it's important for us and for you to tell us how many patients, in essence, failed the intervention during the intervention. And similarly, unexpected mortality. We want to know how many people died during the hospital and home episode. There are a couple of less important outcomes that you could report that we'd be interested to see, like unplanned staff call-outs and unplanned patient telephone calls. But the first two are things that we will look for in your papers when you submit them. Now, there are also we want to know about all the other outcomes that you can report and that everyone will report as part of their research. Length of stay, readmissions 30 days after discharge. So this is where we get confused, and a lot of people use the term readmission, and that includes people who return to hospital during their hospital home stay. We want you to separate them, because a readmission rate 30 days post-discharge means exactly that. And so when you're discharged from hospital in the home, then you can measure the 30-day readmission. We're very happy to hear about that. But don't mix this with patients who are returned to hospital during their hospital and home admission. Same with mortality. Of course, we want to know about patient and carer satisfaction. And of course, we want to know about any condition-specific outcome that you get into, pneumonia, cellulitis, any ID, any oncology outcomes, any condition or drug-specific outcomes or severity score changes over the course of a treatment or complications. We're very happy to hear about those. So we come to the end. I hope you agree that this is kind of necessary given how quickly we're growing, and I hope it's taken in that faith, in that manner. That what is expedient is not always best. We're all grown-ups. We all operate in systems. We're in some cases the lowest rung on the very, very tall ladder of health service provision, and we have to fight to be heard, and we sometimes have to make compromises. And that's great, and of course we have to make compromises, but this conference is not the place necessarily where we have to accept those compromises. This is the place where you can take what happens here as a tool, as a weapon, back home and beat people with it. So let's not accept what's expedient here if we can avoid it. And we think that the foundations do need to be solid, even with what's on top is different. So you need to build them firm, you need to know what you're doing, you need to take the experience of others to build the foundation, and then what goes on top depends on what's around, depends on the skills, the interests, the cultural context of what it is that is the community, the health community that you've grown up in. And they'll be different, and that's why we come here. If we were all the same, we wouldn't have to come to an international congress.